See.
Let's wait just a few more minutes and see if, or a minute or two, and just see if we get more people. Just for a second. What? All right, let's, even though we still don't have a lot of people here, let's just get started. Okay, so your third case study is posted. And I posted it just so that you would get a chance to look at it, but it's not going to be due until about the end of the semester, which I know is coming up anyway. But if you look at it, a lot of it has to do with the muscle and neuromuscular junction, which we will talk a lot about in about a week. Show it to you really quick. And some of this is more, there's a few questions here that are more, how do I put it? You need to go back and look at other chapters. Let me show it just a sec. So it's right here. And I'm not going to read through all of it because there's a lot of the story behind it. The beginning here, this first part is all about excitation, contraction, coupling, which we will be talking about in about a week to 2 weeks. And what is a voltage-gated sodium ion channel? What do you think a voltage-gated sodium ion channel is? You know what it is. You just need to think back on it. Someone tell me, what do they think it is?
It has something to do with the plasma membrane and
It does.
it exchanges the like sodium and potassium kind of go
Right.
in and out of the cellular membrane.
That's the sodium potassium pump, and you're close, but it is what's going to initiate an action potential. If you remember, there are voltage-gated sodium channels which allow for the depolarization of the membrane. What is it made of? Well, what are most channels made of? Go and look in your textbook. You'll find the answer. They're usually made of hydrophobic residues. Describe the process by which they move through the channel. Well, how do they move through the channel? How do they move through the channel?
Junctions?
Because you're moving through a channel, and the channel is essentially your junction. How do most things move?
Maybe diffusion?
Yep, diffusion. And is it simple diffusion, or is it facilitated diffusion? What do you think it is if it's going through a channel?
I think facilitated.
It's facilitated, you're right. So that's the answer for that question. That's why I'm saying you need to go back and look at some of the other things, and this will make a lot of sense. Let's see here. What is happening to the electrical potential when it generates an action potential? And what is the function of an action potential in neurons? Well, what's happening first?
Doesn't it receive a message first to change the situation, whether it's by like, I don't know, maybe negative or positive?
A ligand or a receptor that's gonna, and what does it mean when it becomes negative or positive?
It will act upon like, what's the word? Like in that, like to affect or change the situation in the like.
What do we call that when it's becoming more negative or more positive? What do we call that?
Oh, feedback loop?
What do we call that?
I can't think of.
Oh, I was gonna say, is it like a feedback loop?
Not really. I know this is Justin's favorite topic, so, and I can see his face.
Polarization and depolarization.
Exactly. Okay. so
I hate this subject, Mary. I hate it. I hate it.
That's why you love this subject. That's why you love this subject. So depolarization and repolarization. This charge difference will describe this potential when the neuron is at rest. What is it when it's at rest? It's about -70 millivolts, right? Let me know, read through it, and let me know over the next couple weeks in lecture or lab if you have questions about it. All right, let's I want to finish chapter 14 and start chapter 15. I think I also set up your, maybe not. Never mind. I haven't done it yet. I will open up your second exam tonight. And then your third exam will cover chapters 15, 16, and 11. Okay.
When is the second case study due?
I think we said like around April 20th.
Yeah, April 20th.
9 days. All right, let's jump into tonight.
Sorry, I don't know if this was already talked about, but the chapter 15, like smart book or quiz was due tonight, and the other one was due on April 15th or something like
I
that.
will push them back.
Okay. I was just wondering.
Yeah,
Okay,
I'll push them
thank
back.
you.
I'll push them back right after class.
Cool. Thank you.
Welcome. It will be pushed back. We will finish chapter 15 tonight. You'll see it's not very long. We may also start chapter 16. Let's just see what happens. So we kind of did this, we did the end, we went through the rest of the cranial nerves and we skipped part of the end of chapter 14. So I'm going to go back and cover it. And I think it was like from slide 87 to slide 106, approximately. I think we were about right here. So differences in the structure and function of the two hemispheres. The left hemisphere tends to be more specialized for spoken and written language, sequential and analytical reasoning, math, and science, and breaks the information down into fragments and analyzing it. So looking at a problem from multiple angles and assessing where the problems are. Says that in 96% of left right-handed people, your left hemisphere is the predominant one. I'm not sure just how much I agree with some of that. Right hemisphere perceives information in a more integrated way. It's a site of imagination and insight, musical and artistic skill, perception of patterns and spatial relationships, and comparisons of sights, sounds, smells, and taste. In 70% of people, the right hemisphere is predominant. The right hemisphere is predominant for 15%. And then, of course, that doesn't look right at all. Okay, in 70% of left-hand people, the right hemisphere is predominant. In 15 additional percent, the left hemisphere is predominant. And in the other 15%, it's not specialized one way or another.
What does predominant mean in that sense?
It means that it tends to be the overriding factor. And if you're like me, I'm not sure just how much I agree with this. If it's correct, I'm left-handed, and I can say that at one point I had probably a little bit of artistic skill, but it was never really great. And when it comes to perceptions of patterns and spatial relationships, I don't think that's a strong suit for me either. But side of imagination and insight, maybe at one point in my life, but I think it's changed. Because at one point I was much more of a writer than I am now. And at one point I was much more artistic than I am now. So I think I wonder if it changes over time depending on what you're working on. Do you agree? For you guys who are right-handed and left-handed, do you agree? Yeah, it doesn't seem like the heads that I'm seeing shaking are letting me know that you probably don't completely agree. So cognition is the range of mental processes by which we acquire and use knowledge. Involves sensory perception, thought, reasoning, judgment, memory, imagination, and intuition. Cognition is accomplished by the coordination of distributed associated areas of the cerebral cortex. So we talked about primary cortexes, and then we talked a lot about association areas, and we'll talk more about association areas here, where they're coordinating. It feels like this, it sounds like this, it probably is this. So your association areas account for about 75% of all the brain tissue. Researchers learned more about cognition from studies of patients with brain lesions and from imaging studies using positron emission tomography or Fourier magnetic resonance imaging. So the prefrontal cortex, and I'm going to zoom out just a little bit here. Prefrontal cortex is the site of judgment, intent, and control over expression of emotions. Primary sensory cortex. Right, where was primary sensory cortex? Primary somatosensory. Wait, let me think here. You know what? I was gonna say something, but I think I'm gonna be wrong, so I'm not gonna say it. Primary sensory cortex, the site where sensory input is first received. And then one becomes conscious of that stimulus. So your primary somatosensory, remember what somatosensory means. Somatosensory meaning skin, muscles, bones, and joints. Your primary gustatory cortex, your sense of taste. Primary visual cortex, something you see. Well, how does it relate to what you've seen in the past? That's your visual association area. Primary auditory cortex. You hear something for the first time. Well, how does it compare up against what you've heard in the past? So association areas that are near the primary sensory areas will process and interpret that sensory information. So special senses are limited to the head that has sense organs that include vision, hearing, balance, taste, and smell. General somatosensory are associated with touch and anywhere that has a lack of special sense organs. Primary visual cortex is in the occipital lobe, so far posterior region of the occipital lobe. The visual association area makes cognitive sense of what you're seeing. Much of the inferior temporal lobe deals with recognizing faces and familiar objects. One thing that I'm curious about is because you know that Wernicke's area is a language area. When you learn to read, I think you are training all three, the primary visual, the visual association area, and the Wernicke's area. Because if you think about that, you learn to associate letters with words, and then you learn the meaning of those words. And then you learn how to communicate using those words. So much of the inferior temporal lobe deals with recognizing familiar faces and familiar objects. Hearing, probably the easiest to determine because most of it is in the temporal lobe and the insula. Primary auditory cortex in the superior region of the temporal lobe and insula. Primary association area recognizes spoken words, a familiar piece of music, or a voice on the phone. Wernicke's area is also involved in recognizing voices on phones. Gustavatory is received by the primary gustavatory sense that's in the inferior end of the post-central gyrus. So remember, here's your central sulcus. So pre-central gyrus, post-central gyrus. Olfactory signals are received in the medial surface of the temporal lobe. Medial surface of the temporal lobe. And inferior surface of the frontal lobe. Right where your olfactory bulbs run. If you think about that. Because if you inverted this and you looked at where the cranial nerves are, that's where they lie. So general senses or somatosensory senses. Ascending tracts bring the general sensory information to the brain, and the somatosensory relates the sensations that occur anywhere in the body in contrast to one localized sense organ. So here we're looking at the central sulcus, the primary somatosensory cortex is right here. Somatosensory association area is right here. So it relates to sensations that can occur anywhere in the body. And this information is all relayed through the thalamus. So the thalamus is going to selectively relay signals to the primary somatosensory cortex. So primary motor cortex, the precentral gyrus, primary somatosensory cortex is the postcentral gyrus. This is where your first awareness of the stimulus is initiated. The somatosensory association area is where you're actually going to identify and classify and categorize whatever you're feeling. So makes the somatosensory association area is going to make sense of that stimulus. Sensory homunculus, they've been able to identify what senses are associated with what regions of the postcentral gyrus or somatosensory cortex. So genitalia tend to be deep within the longitudinal fissure. And you can see that they take up a fairly large spot in comparison to the hip or the wrist. Toes tend to be fairly sensitive. Your fingers are extremely sensitive, take up a major region. Your tongue, your eyes. If you think about the most sensitive parts of your body, you know that this area would, it's intuitive that that area would take up more space or have more of the cortex associated with its function and with assessing what was felt there.
And by eyes, it means like pressure on the eyes or like pain in the eyes, right? Yeah. Not like visual stimulus.
I would think that would be it. Pressure and pain. That has to be bear with me here as I think for a second. A protective reflex. We were talking about eyes this last week. And I'm glad we went through that lab. I'm glad that Justin's little girl knew that we needed to go through that lab. I was talking with somebody. No, my mom and I have a friend who she got something in her eye. And she actually went down to Johns Hopkins and had surgery on her eyes, and then got like a muscle relaxant accidentally in her eye from a patch. And she went in to have, well, she went in to have this procedure, and then she got this muscle relaxant in her eye. And all of a sudden her eyes really start hurting. And she was told that it was normal behavior. It was normal for her to deal with pain. And my mom, who's not here, she was like, no, pain is not normal. If you're having pain in your eyes, that's not normal. And this person that we know, her husband's dad was once the department chair for the ophthalmology department there at Johns Hopkins. And so when he called home and he said, what have they said about your eyes? And she said, well, they said it's normal. And he just about blew a gasket. And he's like, no, it's not normal. This is not normal. And he then called and she got in. And there's a pressure amount that you can have of the vitreous humor before it actually starts damaging your optic nerve. And she was like 3 times what she should be. And they said that if she'd waited more than another hour, she could have been looking at permanent blindness from this. And so I think it's honestly, it's a protective response of your eyes. Yeah, I mean, she's fine, but because I've learned some information from dealing with an ophthalmologist that when you have pressure in your eyes, it can be for a lot of different reasons. Usually they look at it for glaucoma, but they're realizing that that's not when they've blown the air in your eyes. That test is actually not very good at this point, because there's a lot of things that can cause pressure in your eyes. What they need to do is look back at the optic disc and see what that nerve looks like. Because if it looks damaged, it doesn't matter whether you have pressure in your eyes or not. It looks damaged. I learned that from one of my most recent eye appointments. I started asking the ophthalmologist, and he started telling me that test was not very valid. So I think that's part of the reason you've got so much of your cortex associated with your eyes.
Really quick with the homunculus, the other day my guys pointed me to it. If you Google image search, either type in the homunculus or the way your brain sees your body, there's a really interesting visual on how the cortex views, like how the cortex sees our body. It's kind of a disturbing little image, but it's really interesting.
I'm a little worried.
Well, basically where all the sensory comes from. I can't get in there. There we go. It's interesting. They told me about it. I'm like, what are you talking about? And they're like, just look it up. It's interesting. There's a little like
What did it do? Homunculus.
Homunculus, yeah.
Oh.
Yeah.
Okay. Oh, that's terrible. All right. So we're really all hands and lips and not much else. Okay. Well, I guess I'm not really that shocked. That's funny. Huh. I may have to add that to my PowerPoint.
Isn't that interesting?
It's interesting, and it makes you really wonder. But one thing that you also learn about the homunculus is, why do babies put everything in their mouths? Because they can learn more about that object by sticking it in their mouth than they can any other way.
Well, and it makes sense because it all goes from hands to tongue and lips, basically.
Yeah.
Yeah.
Wow. Huh. I may have to add one of those. That's funny. All right, where was I don't know. It's gonna make me go right back to the beginning when I do that. So looking at the post-central gyrus, remember this is your, what we were looking at here, bear with me. No, never mind. Okay, post-central gyrus, showing where the receptors from the face project to the inferior and lateral parts of the gyrus. Somatotropy is a point-to-point correspondence. The motor area, so primary motor cortex is the precentral gyrus, and the motor premotor or association area or association premotor area is right in anterior to it. So you think about an action you're going to perform and remember how much your cerebellum is involved in this. So there's a lot of interchange and exchange of information between planning out that movement and then dealing with environmental feedback and adjusting it accordingly. And just like the post-central gyrus that exhibits somatotropy, your precentral gyrus does also. So neurons for toe movement are deep within the fissure. At the summit is the trunk and the shoulders and the arms. And inferior lateral region is going to control your facial muscles. So Wernicke's area, found posterior to the lateral sulcus, usually within the left hemisphere, and it permits the recognition of spoken and written language. When we intend to speak, Wernicke's area formulates phrases and transmits that part of speech to the Broca's area. But it's also involved in you being able to recognize what you read. And the Broca area is what's going to be controlling the muscles of your mouth and the pattern by which they move. So damage to the Wernicke's area is going to allow someone to properly form words, but they can't put them into a coherent sentence. You can understand why that would be really frustrating for a stroke victim. Broca's area, found in the inferior prefrontal cortex, usually in the left hemisphere. It's generating the motor program for the muscles of the larynx, tongue, cheeks, and lips for speaking and for hands when signing. It's amazing if you think about it, how much training your mind comes into your ability of language. This program is then transmitted to the primary motor cortex for commands to lower motor neurons to supply relevant muscles. So damage to the Broca's area when there's damage to the Broca's areas, one can understand language but cannot properly form the words or produce speech. Okay, and this is where we picked up and finished. Are there any questions? I think more than anything, I hope you get a really good grasp of how much integration is going on here. Because I can tell you that my students at Stevenson struggle to process pathways of integration between these different areas. But there's so much interaction and so much interplay. Any questions or comments or thoughts? I think I will be adding that picture of that homunculus to my thing. Because all right, let's jump into the autonomic nervous system. So I will open up the second exam tonight, and it will be open for at least a week. So autonomic nervous system and visceral reflexes. Two major divisions of the peripheral nervous system. The somatic nervous system, which is generally your voluntary skin, muscle, joints, and bones. If you think about this, this isn't completely always voluntary. If you think about the motor spinal cord reflexes that we talked about, they're not voluntary. I think a lot of it, you train yourself to a certain level. Autonomic visceral, meaning involuntary. Can you train it to a certain level? I think you can. I told you at one point I was well known. I don't know if I said this or not. I was well known in my family for my abilities to faint. I don't have that issue as much as I did a while ago. I still can do it depending on what happens. I try to avoid situations where I know I'm likely to get lightheaded. But you can train yourself to avoid certain things and to recognize the signs. So refers to internal organs like heart, lungs, liver, stomach, etc. Autonomic nervous system includes the sympathetic division, the parasympathetic division, and the enteric division. Whether or not the enteric division is automatically included as part of the autonomic nervous system is not always, it's not always agreed upon. However, it governs itself to a certain level. But it does get feedback from the other nervous systems, and we'll see that when we talk about it here. Absence of a sympathetic nervous division is not fatal. You just need to deal with low stress situations. Absence of a parasympathetic division is fatal. If you read the very beginning of your book, talks about some studies that were done in dogs. He could stop the sympathetic nervous system, but those dogs could not be put in high stress situations. However, blocking the parasympathetic division through cutting the vagus nerve was fatal. So an absence is fatal because the body cannot maintain homeostasis without it. Polygraphs work because most autonomic responses cannot be consciously altered or suppressed. Effectors and the physiological effectors of an examination are directed at the autonomic nervous system, looking at blood pressure, breathing rates, and sweat skin responses. Autonomic nervous system maintains homeostasis by regulating the activities of smooth muscle, cardiac muscle, and glands. Summary slide comparing the somatic and the autonomic nervous system. Somatic nervous system comes from the somatic senses and the special senses. Autonomic nervous system, in contrast, some are coming from the somatic senses and special senses, but many are interoreceptors. Interoreceptors mean visceral receptors. Think about it as being internal receptors. Output from the somatic motor nervous system is going to involve voluntary control from the cerebral cortex and contributions from the basal ganglia, cerebellum, brainstem, and spinal cord. Autonomic nervous system is involuntary control through the limbic, hypothalamus, brainstem, and spinal cord, and limited control from the cerebral cortex. The somatic nervous system is a one neuron pathway. Motor neurons from the central nervous system are going to synapse directly with the effector. In the autonomic nervous system, they're usually a two neuron pathway. You have preganglionic neurons that extend from the central nervous system. They're going to synapse with postganglionic neurons. Think of it the same way we thought of presynaptic neurons and postsynaptic neurons. Rather than having the synapse be the place where the presynaptic neuron joins up with the postsynaptic neuron, now we're talking about ganglionic. So we're saying the one neuron comes from up until the ganglion, and then the postganglionic neuron synapses there with the preganglionic neuron. And we'll see it again. We'll delve more into it as we go here. Alternatively, preganglionic neurons may extend from the central nervous system and synapse with chromaffin cells of the adrenal medulla, which puts out a lot of sympathetic hormones. All motor neurons release acetylcholine. All somatic motor neurons. All sympathetic and parasympathetic preganglionic neurons are going to release acetylcholine. Most sympathetic postganglionic neurons are going to release norepinephrine. Remember, these are all neurotransmitters. Those to sweat glands, postganglionic neurons that are going out to sweat glands are going to release acetylcholine. All parasympathetic postganglionic neurons are going to release acetylcholine. Chromaffin cells, where preganglionic neurons are going to synapse with chromaffin cells of the adrenal medulla. The chromaffin cells are releasing the neurotransmitters, or we call them neurotransmitters. Yeah, I guess you remember that there's a gray line between calling something a neurotransmitter or a hormone. It depends on the receptor. So chromaffin cells of the adrenal medulla can release epinephrine and norepinephrine. So they are essentially, chromaffin cells are essentially modified postganglionic cells. We'll see that as we go today. Effectors for the somatic motor nervous system, skeletal muscle, for the autonomic nervous system, smooth muscle, cardiac muscle, and glands. Remember, the somatic motor nervous system is always excitatory. Where was that? It doesn't say that, does it? It doesn't say that, but it's always excitatory. And so the responses are always contraction of skeletal muscle. For the autonomic nervous system, contraction or relaxation of the smooth muscle, increased or decreased rate and force of contraction. So increase or decrease secretion of glands. So it can be either excitatory or inhibitory. So one is always excitatory. One can be both. So the parasympathetic nervous system, autonomic nervous system, always uses enteroreceptors or visceral receptors. So sensory receptors located in the blood vessels, visceral organs, or muscles. Use mechanoreceptors. What are mechanoreceptors? The mechanoreceptors. Mechanoreceptors would be like those that we saw in the ears, where you pull them open. They get bumped and they get pulled open. Chemoreceptors are going to have ligands that bind to them. For example, those would be found in your nose and in your mouth. Photoreceptors of light. What are baroreceptors? We've talked about this before, baroreceptors. Maybe not.
Pressure receptors.
Pressure, right. I like to think of a barometer, measures pressure, so it's a receptor that's measuring pressure. Thermoreceptors, measuring temp. Nociceptors, what about nociceptors? They're measuring pain. Specifically measuring pain. So these all allow the autonomic nervous system to monitor conditions. So we have, just like we had other reflex arcs, we have a visceral reflex arc. We have a sensory receptor, a visceral sensory fiber or an afferent fiber, comes in through the dorsal root ganglion, synapses with a motor neuron or an interneuron. That motor efferent neuron comes out and synapses maybe a preganglionic neuron that then synapses in a ganglion with a postganglionic neuron. So remember, all sensory fibers are going to be one neuron pathways. All autonomic nervous systems are going to be 2 neuron pathways. So sensory neurons are going to carry nerve impulses from a stimulated sensory receptors and blood vessels to the central nervous system for integration. Autonomic motor neurons are going to carry impulses from the central nervous system to the smooth muscle glands and cardiac muscles, aka effectors. So major difference between what you saw before is that rather than having a 1 neuron pathway all the way out to your effector, you now have 2. It's still coming out the anterior horn. We'll find out that when it's sympathetic, it can come out the lateral horn too. But most parasympathetic are going to come out the anterior horn. Actually, let me not even say most, let's say all. So autonomic motor neurons are carrying nerve impulses from this. Oh, I already read that, never mind. Baroreflex. What do you, by just reading the word alone, what do you think this has to do with? This reflex.
Arterial pressure.
Arterial pressure, yes. So baroreceptors found in the carotid sinus and the aortic arch. We also find them in the right atrium. Zena, do you remember this? I don't know where she is, but we were just talking about this because we were talking about regulating renal blood pressure and regulating pulmonary breathing rates. And these also have control there. So carotid sinus senses increased blood pressure. It sends a signal via the glossopharyngeal nerve. Remember, that's one of those that's sensory. It's both. It sends a signal to the medulla oblongata. And the vagus nerve sends out a signal to the cardiac pacemakers that are setting up the rhythm of the heart, decreasing the heart rate, inhibiting the heart rate, and slowing it down. How do you think it slows it down? How would you slow down a nerve impulse?
Maybe you would hyperpolarize it.
That's exactly what it does, is it hyperpolarizes it, making it harder to depolarize. You'll learn later next semester that the heart works on a rhythm. It sets its own rhythm. But if you make it a little harder for it to reach threshold, you'll slow it down.
That loop is in the chapter 15 quiz.
What?
That loop is in the chapter 15 quiz.
It is good.
I took
good.
it today. It's in there.
Good. Dual innervation. So many organs are innervated simultaneously by both the sympathetic and parasympathetic divisions. For example, your eyes, your lungs, your heart. The different effects are because different neurotransmitters are going to respond to different receptors. A given neurotransmitter can be an inhibitory or excitatory. It just depends on the receptor is what's going to determine the action of that neurotransmitter, what the effect is. One thing that you'll see right here just from this diagram alone, presympathetic are coming off the cervical, the brain stem. So actually, do we want to? Yes, the brain stem and the sacral nerves. Parasympathetic. All of the sympathetic nervous system is coming off the thoracolumbar region. This area right here, this is the sympathetic chain ganglion, which is the ganglion for most of the sympathetic nervous system neurons. So an example of dual innervation, like what we saw last week when we were talking about the iris. Parasympathetic fibers of the oculomotor nerve coming out, and so parasympathetic, I thought that's not going to the right place. Parasympathetic fibers of the oculomotor nerve coming out and causing relaxation of the muscles of the iris, allowing for the pupil to constrict. Sympathetic nervous system, on the other hand, is going to send out signals causing the muscles of the iris to constrict, having them dilate, having your pupil dilate. The cholinergic has to do with the receptor. Adrenergic, meaning an adrenergic receptor, cholinergic receptor. So parasympathetic is going to cause the pupil to constrict. Sympathetic is going to cause it to dilate. Any questions? So the subdivisions, the sympathetic nervous system is your automatic fight or flight, prepares the body for intense physical activity, concerned with processes that are going to expend energy. Parasympathetic nervous system is rest and digest, relaxing the body and inhibiting or slowing many high energy functions. Concerned with activities that restore and conserve energy. So sympathetic response is stimulated by the 4 E's: an emergency, excitement, embarrassment, or exercise. You see a bear. You're out hiking, you're enjoying your hike, and you see a bear. The heart rate increases. The liver is going to release glucose into the blood to allow for more glucose to reach your muscles. Bronchioles dilate to allow you for more ventilation into your lungs. Pupils dilate to let in more light. The adrenal glands, via those chromaffin cells, are going to secrete epinephrine and norepinephrine. They give the same but longer lasting effects than those of the sympathetic neurons. Digestive activities are inhibited and the bladder relaxes. You'll notice how little you have to pee when you're scared. Okay, there's no longer a bear around. The threat's over. You've managed to run faster than your friend did, and the threat's over. The parasympathetic nervous system is unconsciously activated, and the body calms down so that it can recover. Heart rate decreases. Liver no longer releases glucose. It's going to start building up glucose stores again. Starts to produce bile in order to detox and to store lipids. Bronchioles of the lungs constrict because you don't need that increased airflow anymore. Pupils constrict because you don't need as much light. You want sharper images. Adrenal glands stop secreting epinephrine and norepinephrine. Digestive activities are stimulated and the bladder contracts. So the sympathetic nervous system and the parasympathetic nervous system are two divisions of which nervous system?
The autonomic.
No, I don't know.
Thanks.
Which of the following effects are mediated by the by the sympathetic nervous system?
Was it C?
It's increased heart rate, correct. We haven't talked about it in this class, but your bronchioles dilating allows for increased lung capacity. Which of the following effects are mediated by the parasympathetic nervous system?
A.
Stimulation of the correct. Any comments, questions? So the autonomic nervous system has components in both the central nervous system and the peripheral nervous system. Control nuclei are found in, remember, what are nuclei? What are nuclei? When we talk about the central nervous system, what are we talking about? We're talking about clusters of cell bodies of neurons. So control nuclei are found in the hypothalamus and the other brainstem regions. Motor neurons are going to be found in the spinal cord and peripheral ganglia. Like the dorsal, no, not the dorsal, never mind. Nerve fibers are going to travel through the cranial and spinal nerves. So comparison of the somatic versus the autonomic efferent pathways. Somatic effectors are always skeletal muscles, and the effect is always excitatory. And they're always myelinated neurons. In contrast, the autonomic nervous system works by a 2-neuron pathway, where the preganglionic neuron is myelinated, but the postganglionic neuron is not. Autonomic effectors are cardiac muscle, smooth muscle, and glands, and the effect can be both excitatory or inhibitory. Let me actually back up just a little bit more here. Motor neurons are always going to secrete. Somatic motor neurons are always going to secrete acetylcholine as an excitatory stimulator. In the autonomic nervous system, in the autonomic ganglion, the neurotransmitter that will be secreted is acetylcholine. The postganglionic neuron can either secrete acetylcholine or norepinephrine. And so effectors for somatic skeletal muscle, I'm just going to go through some of these that we haven't seen before. Distal nerve endings, in the case of the somatic, are neuromuscular junctions. In the autonomic nervous system, they're varicosities, meaning almost free nerve endings. Efferent pathways for the somatic nervous system is 1 nerve fiber, no ganglia involved. In the autonomic nervous system, it's a 2 nerve fiber where there's a synapse of the ganglion. Somatic motor neurons are always excitatory. Autonomic are excitatory or inhibitory. In the somatic nervous system, the damage causes flaccid paralysis. In contrast, on the autonomic nervous system, it causes hypersensitivity. So would autonomic postganglionic fibers have faster or slower conduction speeds than somatic motor neurons?
Slower, right?
Why?
Because
Why?
there's no synapse in between. The autonomic has a synapse for the message to cross, whereas the somatic just goes
That's
straight.
one of them. That's one of them. What's the other reason? I didn't think about that. What's the other reason?
There's no myelination.
Yep. Well, part of it has no myelination. So it's both. Yeah, I didn't think about the fact that the ganglion, but yeah. So preganglionic versus postganglionic motor neurons. Preganglionic is the first of the two autonomic neurons, with the cell body being present in the brain or the spinal cord. It's myelinated and it passes out of the central nervous system as part of a cranial nerve or a spinal nerve. It's going to extend to an autonomic ganglion and synapse there with a postganglionic neuron that's unmyelinated. The postganglionic neuron is the second of two autonomic motor neurons. It lies entirely outside of the central nervous system, and its cell body and dendrites are found in the autonomic ganglion. It can synapse with one or more preganglionic fibers. Remember, we talked about those converging pathways when we were talking about nervous system in chapter 12. Axons of a postganglionic fiber are going to be unmyelinated, and they're going to terminate at visceral effectors. You guys, what are the three visceral effectors? What are the three types of visceral effectors in the autonomic nervous system? What are the three types of visceral effectors? I intentionally just hid them on my screen so you couldn't see them. What are the three things that the autonomic nervous system is going to act on and use to perform responses?
I couldn't remember the third one. Smooth muscle, cardiac muscle, and glands.
Good job, yes. So sympathetic nervous system. I actually, before we do this, I'm going to show you something because we have the time. And I want you to see something. Okay. So here's my really bad picture of a brain. A spinal cord coming all the way down to the sacrum. This is my really rough arrangement of the autonomic nervous system. From T1 to L2, are where all of the sympathetic preganglionic neurons are going to arise. Ganglionic neurons are going to arise. I'm gonna try to make it easier to remember the arrangement here. So the sympathetic preganglionic neurons are rising from T1 to L2. And this part of the spinal cord is also associated with the lateral horn, because the lateral horn contains the cell bodies of these preganglionic neurons. So this is also called the thoracolumbar region, thoracolumbar nervous system or something like that. Thoracolumbar. All of these fibers they're all short neuron fibers, relatively short neuron fibers. Short, actually, let me change this around. Preganglionic fibers. With very few exceptions. There's one exception, the ones that go out to the adrenal medulla. But short preganglionic neuron fibers and long postganglionic fibers. In contrast, the parasympathetic is coming from the cervical and sacral regions. And I can't remember whether they call it the cervical sacral region or what they call it. But this is going to be the parasympathetic nervous system. I think it's cervical sacrum or something cervical sacral. And they have long preganglionic neurons. Plus short postganglionic neurons. So right down here, I missed a word. Right down here, so it should say short preganglionic neuron fibers and long postganglionic neuron fibers. So parasympathetic neurons are going to be flanking the sympathetic nervous system preganglionic fibers. And they are going to be long preganglionic fibers. They're going to extend out really far. And then have short postganglionic neurons. On the other hand, the sympathetic nervous system is going to originate from the center of the spinal cord. And it's going to have short preganglionic fibers and long postganglionic fibers. Write that down, and you'll make your life and my life maybe a little easier. If you like to think of it in spatial ways, that will categorize them.
Can you say that again?
Well, I've got it right here. I've got it right here.
Write it down, which I did.
Yeah, let me see here. So parasympathetic nervous system is going to come off the ends of the spinal cord. It's going to come off the brainstem and the cervical plexus and the sacral region. It's going to have long preganglionic neurons and short postganglionic neurons. The sympathetic nervous system, on the other hand, is going to come off the center, and it's going to have short preganglionic neurons and long postganglionic neurons. And the cell bodies for the sympathetic nervous system preganglionic neurons are found in the lateral horn. Somewhere along the line, I developed that pattern in my head, and it made it easier for me to remember some of this. Did you get it down?
Yes, thank you. I appreciate it.
Of course. So the thoracolumbar region, the preganglionic fibers, neurosomas, remember those are cell bodies, are located in the lateral gray horns. They're going to exit the spinal cord from T1 to L2. And they're going to lead to the nearby sympathetic chain ganglion, which is also called the paravertebral ganglion because it runs right next to the vertebrae. The sympathetic nerve fibers are distributed to every level of the body. Because they distribute throughout the body, they show a very high level of neural divergence, branching out networking. They have short preganglionic fibers and long postganglionic fibers. So yes, some of this will be a review of what I just said, but just humor me for right now. The paravertebral ganglia, remember, this is also called the actually, bear with me here. We're going to put it somewhere else. Let's do this. Paravertebral ganglion. Vertebral ganglion. It's also called the sympathetic chain ganglion. Or authentic chain ganglion. So the neurons from the sympathetic nervous system are going to, their cell bodies are going to be in the lateral horn inside the spinal cord. And then they're going to extend out to the sympathetic chain ganglion, which runs right next to the vertebrae. So they're going to be small myelinated fibers that will then connect. Excuse me, each vertebral ganglion is connected to a spinal nerve via two branches of the rami communicante. The preganglionic fibers are small fibers that travel from the spinal cord to the ganglion by way of their white communicating ramus. Remember, white always means myelinated, gray means unmyelinated. postganglionic fibers are going to leave the ganglion by way of the gray communicating ramus. So the white communicating ramus is going to bring the preganglionic fiber, or it's going to be the mode by which it enters the sympathetic chain ganglion. The postganglionic fibers are going to leave via the unmyelinated gray communicating ramus. Because remember that the postganglionic fibers are unmyelinated. And they're going to extend the rest of the way. The postganglionic neurons are going to extend the rest of the way to the target organs. So they're going to enter via the white communicating ramus, and they're going to leave the spinal cord via the gray communicating, leave the ganglion. The postganglionic fibers are going to leave the ganglion via the gray communicating ramus. So the white rami communicantase is going to carry the preganglionic sympathetic fibers from the spinal nerves to the sympathetic chain ganglion. The gray rami communicantase is going to carry this postganglionic sympathetic fibers from the sympathetic chain ganglion to the effector organs. After the preganglionic fibers that are coming in via that white rami communicantase, once they enter the sympathetic chain ganglion, they can go one of three courses. The first one is that they can enter the ganglion. They enter, so here they are in the lateral horn. Here's the cell bodies in the lateral horn. They enter out via the anterior horn and immediately enter the paravertebral ganglion. When they are here, they can immediately synapse on a postganglionic neuron. That's one pathway. And that postganglionic neuron is going to leave as an unmyelinated nerve fiber, or the gray ramus communicante. Alternatively, it can travel up and down the chain and synapse in the ganglia with another postganglionic neuron at a different level. With another gray rami communicantase. Or alternatively, they can pass through the chain without synapsing and continue as splanchnic nerves that lead to a second set of nerves called the collateral ganglia. So they can immediately, so three different pathways. They can immediately enter the anterior horn, come out, enter the sympathetic chain, and immediately synapse with a postganglionic neuron. Or they can pass up and down. The second pathway is they can move up and down the chain and synapse at a different level with another postganglionic neuron. or they can pass through the chain without synapsing with any ganglions and lead to another ganglion called the collateral ganglion. Questions? So the collateral ganglion, or the prevertebral ganglia, also called the prevertebral ganglia, contributes to the network called the abdominal aortic plexus that wraps around the abdominal aorta. Many postganglionic fibers are going to exit this plexus and accompany arteries with the same names and follow the same routes to their target organs. So the collateral ganglia is going to become a plexus that's going to wind itself around the abdominal aorta. Couple different ganglia that belong to the collateral ganglion. The celiac ganglion, which is going to have postganglionic neurons that are going to target the stomach, the spleen, the liver, pancreas, small intestines, and kidneys. The celiac and supramesenteric ganglia, which are going to target the small intestines, colon, and kidneys. The lumbar ganglia, which are going to synapse in the inferior mesenteric ganglion, going out to the rectum, the urinary bladder, and the reproductive organs. If it helps you to remember, celiac disease has something to do with the intestines and the stomach. I know it's an autoimmune disorder, and I don't know a whole lot about it, but if it helps you remember what ganglia targets those organs. Supramesenteric nerves tend to target the small intestines and part of the large intestines, the colon. Inferior mesenteric tends to be the urinary bladder and the reproductive organs. Any questions? This right here is just saying where they originate from along the spinal cord. Let me finish with the sympathetic nervous system, and then we'll take a short break here. Sympathetic innervation of the adrenal medulla is an exception, because the preganglionic fibers are not going to synapse in the sympathetic chain ganglion that are going out to the adrenal medulla. They're going to go directly to the adrenal medulla and release acetylcholine on the chromaffin cells. And the chromaffin cells are modified cells that are going to release epinephrine and norepinephrine, or adrenaline and noradrenaline. So they're modified postganglionic cells, neurons, and that they can respond to the preganglionic neurotransmitter acetylcholine. So preganglionic fibers exit the spinal cord via the what and pass through the what to enter the what.
Is it A?
A. No, it's not A. Bear with me. Is it A? Bear with me. Let me think just for a second here. No, it's not A. The lateral horns are not where they're going to exit. They're actually going to exit via it's not listed here.
Is it C?
It's not, because the dorsal root is sensory and these are going to be motor.
Is it B?
It's B. Bear with me. I'm going to zoom in on this picture really quick. So here, this is where the cell body starts. It's going to come out via the ventral root or the anterior horn or anterior root. Come out and pass through the sympathetic chain ganglion. And leave via a rami communicantes. Let's do one more. Primary reason that you guys, is that clear how that works? Before I skip over it. This part right here, where it's passing out, is going to be the white ramus, the myelinated preganglionic neuron. And then it's going to enter the sympathetic chain ganglion. So anterior or ventral root coming out and moving around the sympathetic chain ganglion. Is that clear? Nobody's saying anything.
It is now until tomorrow.
I understand that kind of thing. Okay, so the primary reason that the sympathetic division of the autonomic nervous system produces immediate responses on the body is based on the concept of divergence. True or false? I'm going to skip. Go ahead. What were you going to say, Zena?
True.
It is true. If we come up, So distributed to every level, demonstrating a high neural divergence. All right, you guys, let's take a few minutes here and get up and move. I'm sure you need to get up and move, and I need to get up and move. So let's take until 7:15, come back. What are you doing? You gonna get up here? Come on. All right, so let's come back to this. The parasympathetic division is going to arise from the brain and the sacral regions of the spinal cord. Oh, blah. Sorry, lots of hair in my face. Been petting my cat. Okay. Yeah, I know you like being pet. Is going to arise from the brain and the spinal cord. They're going to travel, the fibers are going to travel within certain cranial and sacral nerves. They have, in comparison to the sympathetic nervous system, they have long preganglionic fibers where the axons are going to end in terminal ganglia in or near the target organs. And they're going to have, and because the terminal ganglia are going to be in or near the target organs, as a result, we're going to have short postganglionic fibers. If you want to think about it, neural divergence would be a branching off of the postganglionic fibers. We don't have that here. We don't have a lot of branching off of postganglionic fibers. So there's going to be very little neural divergence. So long preganglionic fibers whose axons are going to end in the terminal ganglia at or near the target organs and have very short postganglionic fibers. Three major nerves, and I think this is also one of your answers on your case study for the cranial nerves. Four major nerves that are working specifically with parasympathetic innervation. Oculomotor nerve works to narrow the pupil and focus the lens. The facial nerve works on tears, nasal, and salivary glands. Glossopharyngeal nerve working on the parotid salivary glands. And the vagus nerve working specifically for many different organs. So if you remember towards the very end of the cranial nerve case study, it's asking about nerves that are specifically more involved with the parasympathetic nervous system. That's your answer right there. The remaining parasympathetic nerve fibers are going to arise from S2 to S4, sacral nerve 2 to sacral nerve 4. And are going to form the pelvic splanchnic nerves. So 4 cranial nerves, and sacral nerves S2 through S4. The ones that are coming off S2 to S4 are going to form pelvic splanchnic nerves that are going to lead to the inferior hypogastric plexus. Think what hypogastric means, under the stomach. So this would be areas, internal areas that are underneath the stomach. For example, your reproductive organs, your bladder, your rectum. I'm sorry, my nose is all itchy because I've been scratching my cat during the break, and now I'm covered in cat hair. But he's thoroughly happy, so that's all that matters. Origin of with regards to comparison of the sympathetic and parasympathetic nervous system divisions. Origin in the central nervous system for the sympathetic is at thoracolumbar. Parasympathetic is craniosacral. The ganglia for the sympathetic is the paravertebral ganglion or the sympathetic chain ganglion. The terminal ganglia are near or within the target organs. Fiber lengths. In the sympathetic, we have short preganglionic fibers and long postganglionic fibers. I do have a minor cat allergy, especially when it's all over me, so bear with me. Neural divergence extensive for the sympathetic. For the parasympathetic, it's minimal. Effects for that system widespread in general for the sympathetic and more specific and local for parasympathetic. Any questions? So the enteric nervous system, like I said, it's sometimes debatable just where do we put this system. But it is involuntary. And it is influenced by the autonomic nervous system. And so this is where we're choosing to study it, is that it's part of the autonomic nervous system. It includes two plexuses, the myenteric plexus and the submucosal plexus. The myenteric plexus predominantly regulates gastrointestinal motility, the movement of food and substances down the GI tract. Submucosal plexus is going to be specifically controlling secretions. So it's somewhat regulated by both the sympathetic and the parasympathetic nervous system. That's really all we're going to say about it. Are there any questions? So how do autonomic neurons, have contrasting effects on the same organs? Well, two different ways. They can secrete different neurotransmitters, and the receptors on the target organs can vary. Target cells can respond to the same neurotransmitter differently depending on what receptors are present. When you talk about the endocrine system next semester, a hormone will not affect a cell unless the cell has a receptor for that hormone. Same thing here. And the receptor is what's going to dictate whatever response occurs. And so a given neurotransmitter may be inhibitory in one effect and excitatory in another situation, depending on the receptor that it binds to. Despite the massive variety of possible chemicals that could be used as neurochemical messengers in the autonomic nervous system, only acetylcholine, norepinephrine, and epinephrine are used to any degree. Remember, there's over like 100 neurotransmitters, but we only use mainly 3. Synapses at which acetylcholine are used are considered cholinergic. So acetylcholine binds to cholinergic synapses or synaptic receptors. Cholinergic receptors. We have 2 different types of cholinergic receptors. We have nicotinic receptors, and we have muscarinic receptors or muscarinic receptors. Bear with me, I'm gonna, because I think there's a lot of information here, and I'm going to work to try to classify some of it. 2 types here. 1, nicotinic. Do you know where the name comes from? Can you take a guess? This is the receptor that nicotine binds to. That's where the name comes from. Nicotine mimics in structure acetylcholine. Muscarinic comes from the really nasty toxin muscarine that binds to this receptor. And if I remember right, it's a paralyzing toxin. So nicotinic receptors and muscarinic receptors. synapses for all preganglionic fibers in both divisions, both the sympathetic and parasympathetic nervous system, autonomic nervous system, and all those postganglionic fibers are going to be cholinergic synapses. So the synapses are named according to what receptors are present. If the receptor that's present there is a nicotinic receptor, then it's a cholinergic receptor. Excuse me, why did I say that? I don't know. Acetylcholine binds to nicotinic receptors. Both of these receptors are cholinergic receptors, and therefore they're both cholinergic synapses. Does that make sense? Kind of. Is it clear? So the two types of receptors that are found at cholinergic synapses are nicotinic receptors and muscarinic receptors. And these are the synapses found in all preganglionic fibers in both divisions and all postganglionic parasympathetic neurons. Any receptor that binds acetylcholine is a cholinergic receptor, and there's two types: muscarinic receptors, which are found on all cardiac muscle, smooth muscle, and gland cells. And they can be excitatory or inhibitory due to the different classes of muscarinic receptors. Nicotinic receptors are always found at the end of the postganglionic fibers within the adrenal medulla. And you know what? That's wrong. I've just read it and I thought that doesn't look right. You guys, this should say preganglionic. Well, wait. No, it's preganglionic. It's preganglionic. Because we don't remember that in the adrenal medulla, we don't have postganglionic neurons. We only have chromaffin cells that are modified postganglionic neurons. Change that right after class tonight, but it should say preganglionic, not postganglionic. And they're always excitatory when acetylcholine binds. Any receptor that binds, okay, so we already said that. Nicotinic receptors, always found at the end of postganglionic neurons at neuromuscular junctions that are excitatory. Remember actually, I'm not going to say that. So that it's found at all neuromuscular junctions. And somatic motor neurons. Always excitatory. Questions? So nicotinic and muscarinic receptors are both going to bind acetylcholine. And the synapses where you find these two receptors, because they bind acetylcholine, are called cholinergic synapses. Just to summarize here. Adrenergic neurons are found in synapses where epinephrine, norepinephrine, and epinephrine are termed adrenergic. Erase some of this, but not all of it. So epi meaning epinephrine. And Ne meaning norepinephrine. And these are always going to be found at adrenergic receptors, because adrenaline was the first word that why we called epinephrine. Epinephrine was originally called adrenaline. Norepinephrine was originally called noradrenaline. So these are secreted at adrenergic synapses. Synapses. These are the synapses for nearly all sympathetic postganglionic neurons. We have two types of adrenergic receptors. We have alpha adrenergic receptors. We have two classes. We have alpha 1 that's usually excitatory, and alpha 2 that's usually inhibitory. And then we have beta adrenergic receptors. Beta 1 and beta 2 that have different effects that can be inhibitory or excitatory. So all adrenergic receptors, all adrenergic synapses have adrenergic receptors. We have two types, or two types with two that have subclasses within each one. Alpha 1 and alpha 2. And beta 1 and beta 2. So in preganglionic fibers, both sympathetic and parasympathetic, they're both cholinergic. So they're both going to secrete acetylcholine. Postganglionic fibers for the sympathetic, some are adrenergic, meaning that they're going to secrete epinephrine, mostly adrenergic, or meaning they're going to secrete epinephrine or norepinephrine. And a few are cholinergic, meaning they'll secrete acetylcholine. A few postganglionic fibers of the parasympathetic nervous system are going to secrete acetylcholine, or they're always going to secrete acetylcholine. Questions? Autonomic tone. The normal autonomic tone is defined as the normal background rate of activity that represents the balance of the two systems, the parasympathetic and the sympathetic. And adjust them according to what the body's needs are at that moment. The sympathetic tone keeps most blood vessels partially restricted and maintains blood pressure. The parasympathetic tone is going to maintain the resting heart rate and maintain smooth muscle tone in the intestines. So it's a balancing act. For example, in the heart has an autorhythmicity to it. It doesn't require for a while, it can beat on its own without any neural stimulation. And it has an inherent beating of about 100 to 110 beats per minute. Most of us don't have a heart rate that high, right? Most of us don't have a heart rate that high. Because the parasympathetic nervous system maintains a lower resting heart rate. So the parasympathetic nervous system is going to decrease the inherent heart rate, while the sympathetic nervous system is going to increase it. And depending on what the body needs at that moment, one of them will have a bigger influence than the other. By doing what Max mentioned before, hyperpolarizing it, hyperpolarizing it so it's less likely to fire action potentials, or depolarizing it a little bit to make it more inclined to fire action potentials. Questions? So the autonomic nervous system itself is regulated by feedback loops between the cerebral cortex, the limbic system. Remember, your limbic system is your emotional input, and the hypothalamus, which is the overall integrator of the autonomic nervous system. So feedback between the cerebral cortex, the limbic system, and the hypothalamus is going to send signals to the brainstem and the spinal cord. So feedback loops that are regulated by the cerebral cortex, limbic system, and hypothalamus. Questions? I'm sorry, my nose is all of a sudden running because I was petting my cat during the break and now I'm covered in cat hair. And I have a little bit of a minor cat allergy. Normally my teaching assistant, my little puppy sitting in my lap, so my cat doesn't jump up on my lap at the same time. Vasomotor tone. This is control without dual innervation. What would that mean? What does dual innervation mean? What does dual innervation mean from before? Guys, what's dual innervation? Go back to one of the previous slides. What is it?
It's when it's innervated by both the sympathetic and parasympathetic.
Blood vessel diameter is only controlled by the sympathetic nervous system. If the sympathetic nervous system is firing strongly, you get strong muscle contraction, resulting in vasoconstriction. If it slows down in its firing, the smooth muscle relaxes and you get vasodilation. This is really important next semester when you study blood flow. So if the sympathetic nervous system is firing extensively, you get smooth muscle contraction and vasoconstriction. If it's not firing as much, you get reduced contraction and thus vasodilation. So kind of shifting gears a little bit, talking about drugs. Generally, most drugs are targeted to our own cells by acting like proteins that can bind to channels, enzymes, receptors, or carrier proteins. We have agonist drugs that mimic the endogenous ligand by binding to the receptor and producing the same effect. Or we have antagonist drugs that are close enough in shape to what the receptor will bind, but will prevent the endogenous ligand from being able to bind and will inhibit the response. Other drugs are targeted at pathogens doing the same thing, working on receptors and enzymes to block them. An enzyme, monoamine oxidase, breaks down monoamines like norepinephrine, epinephrine, dopamine, serotonin, and histamine. Monoamine inhibitors, oxidase inhibitors, slow down the breakdown of monoamines. These inhibit two common types of inhibitors. Two of the inhibitors that are best known, Prozac, aka fluoxetine, blocks the breakdown of serotonin. used to treat depression and anxiety. Levodopa, on the other hand, blocks the breakdown of dopamine and is used to treat Parkinson's disease. Why are amphetamines so easily abused? They chemically resemble monoamines that are associated with elevated moods. Amphetamine has a high resemblance to dopamine. Methamphetamine, probably the most abused drug in the world right now, has a very high resemblance to epinephrine. And mescaline has a high resemblance to norepinephrine. They can either inhibit monoamine reuptake, promote monoamine release, meaning stimulating their release as neurotransmitters, or inhibit monoamine oxidase activity by blocking their breakdown of those hormones. The more you learn, the more you understand why these things are so addictive. Any questions? Thoughts? Beta blockers. So remember, these are acting on the beta adrenergic receptors. Beta blockers prevent norepinephrine or noradrenaline from binding to the beta adrenergic receptor on the heart walls. So norepinephrine would work to be excitatory to increase heart rates. When you take a beta blocker, it prevents adrenaline and noradrenaline from being able to bind to the beta receptor, beta adrenergic receptor. And the result is that the heart rate remains normal even when the fight or flight reactions are a possibility. Even when it's a situation where it could be a fight or flight response, the heart rate remains normal.
I actually learned that at the office that I work at with doing allergy injections. We do not do allergy injections on people who are on beta blockers, because if they go into a reaction of anaphylaxis, epi doesn't typically work for them if they're on the beta blockers.
Oh yeah, because it wouldn't.
Yeah.
Oh wow. Yeah, I've never thought about that, but that makes sense. Any other thoughts? Last slide here. Caffeine mimics adenosine, which is an excitatory neuromodulator. Most of us, a lot of us can say we're addicted to caffeine. Well, this is why. Because of binding of adenosine results in increased acetylcholine secretion, leading to vasoconstriction. So it's mimicking sympathetic nervous system constriction of your blood vessels. Actually, wait, I'm sorry. Now I messed it up. I knew I messed it up. The second I said that, I realized I messed it up. That's what adenosine does, is it's going to work on the sympathetic nervous system to help with vasoconstriction. Caffeine blocks the neuron's ability to secrete acetylcholine by lowering its ability to stimulate action potentials that are going to result in acetylcholine secretion on the blood vessels. And the result is that you don't get the vasoconstriction you would get. So let me say that one more time, because I botched it the first time there. Adenosine is going to work as a neuromodulator to increase the secretion of acetylcholine on blood vessels to cause more vasoconstriction. Caffeine, on the other hand, is going to mimic adenosine. And when it binds to the receptor for adenosine, it blocks that neuron's ability to initiate action potentials and secrete acetylcholine. And the response is that there's less acetylcholine, so there's less vasoconstriction of those blood vessels. Resulting in increased blood flow. If there's less vasoconstriction, there's more blood flow. Questions? Hey, you guys, that's the last slide of this. I'm trying to think if we should even bother starting 16. I'm trying to remember where we were, how many more days we have left of class. Bear with me as I look. Give me 1 second. Because that will make the decision for me. I always think that we have more time than we do. So today is the 11th. Oh. You guys, let's spend 8 minutes starting on it. We'll still finish. I think we're still going to be fine. But let's take 8 minutes and work on this special senses. It's going to be a review for a lot of you because we talked about the ears. Some of it will be a review. Oh, and of course I clicked on the wrong one. Okay, so special senses. So special senses, specifically hearing and balance. So we hear, summary of hearing. Sound waves are compressed air. They're a vibration of compressed air that are focused by the pinna, meaning the outer ear, and they enter the ear canal. And ultimately, they're going to cause the tympanic membrane to vibrate at the same frequency as those compressed airwaves. In the cochlea, those vibrations are going to be changed into electrical messages via depolarizing action potentials. And the cochlear nerve is going to pass those electrical messages to the brain. Semicircular canals are going to be used for balance. Sound, by definition, is any audible vibration of molecules. You hit a tuning fork. I should get a tuning fork, but you hit a tuning fork and it starts to vibrate. How do you hear it? Because your tympanic membrane is going to start vibrating at that same frequency. A vibrating object, for example, a tuning fork, is going to push on the air molecules that are going into your ear. And your eardrum is going to start to vibrate at that same frequency. So the ear hitting the tympanic membrane causes it to vibrate. I can tell you that I just had my hearing reevaluated, and they do this, and what they're looking for is to see what vibrations you hear and what vibrations you don't hear. And they change them up and down, up and down. And sometimes I get, so I'm focusing so hard on hearing them that I may not even hear it. I more like sense that there's a vibration in my ear. And that's how I hear it. The pitch can be high or low and is determined by the frequency. How many vibrations are there per second? Measured in hertz. The loudness is the perception of sound intensity or amplitude. How much air is being compressed? And it's measured in decibels. How big is the amplitude? Not how many wavelengths are there per minute or vibrations per second, but what's the amplitude of the wavelength? Normal hearing range is between 20 to 20,000 hertz. Speech is 1,500 to 5,000 hertz. Most hearing losses are between 250 to 2,050 hertz. Here we are, hertz, 250, approximately right here, to 2,000. So that's why hearing losses tend to affect a lot of speech sounds, is because they're taking up a major part of that region. It's usually when people know that they're feeling hearing impaired is when they can't hear speech. Normal conversation has a loudness of about 60 decibels, so about right here. And the pain threshold is about 120 to 140 decibels. A prolonged exposure to sounds over 90 decibels can cause permanent damage. Okay, and I think that is a great place to stop before we jump into the sections of the year. Do you have any questions for me? Have a good night.
Just really quick for all the things due. So lab 24 exercises will be due tomorrow by midnight, right? And then the lab quest by the 19th, the
Yeah.
case study by the 20th, exam 2 by the 18th. And if
I
chapter
don't,
15
I don't
quiz,
care. Exam
Okay.
due, end of the semester, I don't care. Worry about, when does the end of the semester? When's the end of the semester?
Like the first week in May, we have to have, I mean, I think take our exam.
All right, so don't, first exam, I haven't even, the second exam, when would you like me to make it due? I really do due dates for you guys. I don't do them for me. Have you noticed that? When would you like me to make it due?
personally, I'd like that one to stay sooner because I feel like the more we kind of go on other topics, then
All right, what
Yes.
if I make it due in a week? Is that,
works.
Weeks, right?
say it again?
I mean, I think 2 weeks wouldn't be bad, a week and a half.
All right, let's do 2 weeks.
Do 'em sooner than do 'em sooner.
Let's do 2 weeks. What 2 weeks from today is the, oh shoot, the 15th. So around April 15th, why don't we say April 14th? Because that will be tomorrow, last night at midnight, 2 weeks from last night at midnight.
That's the 24th, right?
Oh, you're right. I don't know what I was thinking, the 14th. Yes, that's the 24th. Thank you. And sorry, I'm dealing with a little bit of an allergy attack here after petting my cat. Normally, there's a reason I keep my puppy in my lap during class. I mean, like I vacuum my bed in my room every night before I go to bed because I don't deal well with, I love cats, but I don't deal well with the hair. And so 24th. Bear with me. Let me look. Are you gonna get, little boy? No, don't call my shirt. You gonna come up here? Come on, Leo, come on, get up here. Yeah, you're my fur man.
When did someone say end of the semester is?
Oh, I don't know.
I feel like I saw on the syllabus May 11th was our last day of class.
May 11th? Is it really
Okay.
May 11th?
May 11th is definitely the end of something.
All right, I think because I start teaching my summer class for Hack on May 11th.
Maybe that was the very end then.
First week in May.
First week in May, okay. So
we do 2
let's,
weeks on that, if we do 2 weeks on the exam, that'll be like a week for the final then too, like for the next one, right?
yes,
That's the only thing I'm worried about. I feel like I'd rather stress a little than stress at the very, very end and freak out.
so what would you like me to do?
I don't want to speak for everybody.
The other thing that I can do, and I can't do it right now. I'm not ready to do it right. Well, I might be. I can look at it and see. Is I can set up, open up both exams. I could probably open up all of them. Could I do that tonight? I could open them all up. And you like that, Elizabeth? I could open them all
And if
up.
some Do them sooner, then you can do that.
Okay, you're really
Otherwise-
quiet. Can you say it just a little louder?
2 thumbs up.
Okay,
Please, is that-
you guys, I think, I can't do it for Bio 122, Xena, because I make up those exams right now as I go. But I think I can open them all up. And so I will make the due date for exam 2 the 24th. But the next 2, they will probably have the same due dates. Like a week after class ends. Does that make sense?
Yes, I think that's great. That way, like we can all work on our own pace
Okay,
since it will be open for a while.
all right, let's do that. Yeah, I should be able to open them up tonight. I think I can do that. Because they're on the same pattern that they were last semester and they're the same questions. All right. Your 4th lab quest is open right now and it will be due on the 19th. Your 5th one will probably, I might be able to open that. Let me look at it. Tonight I'll just open the exams. I'll look at the lab quest 5 later this week. I'm going out of town this weekend, so I know I'm not going to have time this weekend to do a lot. It was kind of an unplanned thing, but I have to leave. But let me open up the exams. The other thing that I can do you guys need a lot when you do the virtual labs? Do you need a lot of explanation going into them? When you do the virtual labs that you've done so far? When you do the virtual labs, do you use a lot of the PowerPoints to go through those virtual labs?
I
No.
don't. really.
It depends.
Would you like me to open them up for you now? Because there's
Yeah,
3,
sure.
yeah, there's 3 more, and then there's 4 more at the end of the semester. Because they're all due with muscle physiology and movement. All right, I'll open those up tonight too.
Thank you.
You're welcome. So all of the exams and the last 4 virtual labs. Don't get overwhelmed that I'm assigning all this stuff tonight simultaneously, because realize that you do have a couple weeks to do it. Other questions? Thoughts?
So I know you're opening
most of it, and then we can work on it at our own pace. I know you,
Uh-huh.
there's a due date for exam 2, which is April 24th,
Uh-huh.
and lab quest number 4 is April 19th.
Uh-huh.
What dates are the case studies due? Because there are no dates like
I
on
don't-
the.
I don't care. I don't
Okay.
care.
I just wasn't sure. I started working on the one, and I realized that there wasn't like an actual due date when you
I don't-
open it up.
I don't close them out.
Okay.
I don't set up those folders so they're gonna close on you.
Okay.
Why don't, I mean, if it makes it easier, give the due date for the cranial nerves next week.
Okay.
And the other one, you won't have all the information for it probably until the end of the semester.
Okay. And as far as the regular lecture, what chapter are we? I mean, like I did 15. Is 16 due yet? Or are we, because we're just
We
starting that?
started it tonight.
Yeah.
And you'll see that the PowerPoint is not very big. It's only 41 slides.
Mhm.
So we will finish it next week and start muscle.
Okay. And is there anything else
Not that I
that
can
you can
think
think of? Okay. Thank you.
of course.
Thank you so much.
Of course.
Have a great night.
You too.
Thank you.
Have a good one.
You too.
Thank you. Have a good night.
Have a good night.
You too.
Have a good night. See you Thursday or Wednesday.
Yep. I understand. Have a good night. Little boy. My boy. Ah. I only really do else for this. It's like, it's-